Okay, can you hear me?
Yes, sir.
Okay, good. So we will start. This is mechanical event of the heart. So these are the ILOs. You can read them leisurely. Uh, so far, last three lectures, the first one basically I described the electrical event of the heart muscles, and then I described the mechanical event. That means in the cellular level, in the each cells, what happened with the calcium entry, actin myosin interaction, and the basically muscle contraction. So in this lecture, I will further go down and try to see the real contraction of the heart, not as individual muscles, as a heart, as a ventricle, as a atria. Uh, what what will happen? What is the contraction? So basically, ventricles, atria will contract and relax. Relax. Please mute your devices, right? So that I will discuss here. And just to start with the lecture, so you, as I mentioned, the SA node will generate electrical activity. It will spread first to the atria, and then, so who is talking? Right. So this is SA node will generate electrical activity, and that will spread to atria, both left and right, and to the AV node. And from AV node, it will go down to the ventricle. Right. So this is electrical activity of the atria, and this is electrical activity of the ventricle as a cell, right? Depolarization and repolarization. So here depolarization and repolarization. So when the electrical activity is spread from SA node to atria, both right and left atria will contract, right? The actually first it will, because SA node is located in the right side, first electrical activity spread in the right and then left, of course, very short time gap. So right and left atria contraction will occur as a result of electrical activity when it spread through the atria and ventricle. So then, it take time. So it take time, and there's a AV delay. That is the most delayed place. And with the delay, it will go down to the ventricle. So it take time, considerable time. Then when the electrical activity enter to the ventricle, it will spread through the ventricle. Again, uh, in the ventricle, electrical activity spread early in the left ventricle than the right ventricle. Of course, very narrow time gap. Somehow electrical activity spread and ventricle will contract, right? So first atria will contract and push the blood down to the ventricle, and then by that time ventricle will get electrical activity and ventricle will contract. Contraction of the ventricle push the blood to aorta from the left ventricle and pulmonary artery from the right ventricle. So as a result of this electrical spread of electrical activity, or contraction will occur in ventricle, first in the atria and then ventricle. Right. So with that, of course, some pressure changes take place. So we know that when these are chambers or cavity, right? So with the pressure, with the contraction of these chambers, pressure will alter. In these three lines, the red line represent pressure change in the left ventricle. Left ventricle. Right. So as example, this is with the ventricular contraction, left ventricular pressure increase and then gradually come down and go down. And this is during the relaxation. So uh, blue line represent the atrial. So this line, I would say is a dark blue line, right? So this blue line represent the atrial pressure change, right? So here also you can see some pressure increase because that is atrial contraction, and then atrial pressure will, because now atria is relaxed, will not change much, constant, but some increase because of the filling with the blood even the way atria is relaxed, right? And so on. This black line represent the pressure in the aorta here, pressure in the aorta. So pressure in the aorta, when the ventricle contract, this is systole, push, when the blood push down to the aorta, aortic pressure increase, you can see aortic pressure increase. This black line is the aorta, and then it going down and so on, right? So these are three pressure lines, and this is the volume, ventricular volume, right? You can see this is during systole with the ventricular contraction, volume reduced because blood will push into the aorta, right? So this diagram I will use again and again to explain the changes in the chambers, pressure changes, and so on. So just to basically this will give some sort of summary about the activity in the heart. This is electrical activity, and this is mechanical contraction, and so on. And this is pressure and volume change, right? So let's move down. Of course, in the heart, this is cyclical change. The first, if we can start description anywhere, from anywhere, just start with the atrial contraction. So this, because electrical activity first spread in the atria will contract, and you can see blood going down to the ventricle. And then the next step, ventricle contraction. The ventricular contraction, because electrical activity now come to the ventricle. Ventricular contraction, there are two paces, very narrow pace called isometric ventricular contraction and proper ventricular contraction or ejection. And then blood will push to the aorta and pulmonary artery. And now after that, ventricles will relax. So you can see now they are relaxed. When ventricles relax, of course, there are two paces, very narrow isometric relaxation. I will explain later. And then blood, when the ventricle relax, blood will come from atria to ventricle. So this cycle will go on, and I will explain each steps in subsequent slides. Right. So just to start with the atrial contraction, we can call atrial systole. Right. So usually systole is the contraction, ventricular systole, atrial systole. Diastole is the relaxed phase. So what was the Sinhala term for systole? As you learn in this in your advanced level, systole වලට මොකද සිංහලෙන් කිව්වේ? When with the contraction. මතකයිද? Anybody? Ventricular systole. What is systole and diastole? What are the Sinhala term? Yes.
Kunche?
Kunche is a systole. Contraction. එහෙමද? අනිත් එක මොකක්ද? Diastole මොකක්ද? කුංචයන් ප්‍රසාරණයද? Sorry? විස්තරණය. Okay, good. Right. So you learn akunchana is a systole. So ventricular systole. Vistarane is a diastole, relaxation. Right. Right. So so we will start with the atrial systole. When the electrical activity is spread to the atria will contract, right? So atrial contraction will push blood to the ventricle. As you can see here, it will push blood to the ventricle. This volume of blood that pushed to the ventricle by atrial contraction is only 25% of ventricular filling. I mean, all the volume will be, we can consider to the ventricle, let's say we get the uh, 3 liter of blood, only 25% of that volume will get through the ventricular systole. So that means before atrial systole. That means before atrial systole or before atrial contraction, some blood already entered to the ventricle. I will explain it in the as a last event. So atrial systole, atrial contraction is important, but that is not the sole or main pace or mechanism to pump blood from atria to ventricle. Even before atrial systole is start, blood is moving to ventricle, and that means even with the ventricular diastole, atrial diastole, when the atrial relax, some blood will go to the ventricle, right? And so in this yellow line represent atrial systole. So as you can see during atrial systole, this is atrial this blue line is atrial pressure will increase, of course, because since blood is coming to the ventricle, ventricular pressure also increase slightly, right? And here you can see ventricular volume. Ventricular volume also increase because blood is moving from atria to ventricle during atrial systole or atrial contraction, right? So now atrial contraction will last some period or some time, and then electrical activity will come to the ventricle after some after some time. So then ventricle start to contract, right? So just forget about this. This is what happened in the ECG. After you learn ECG, probably you can understand this. So that is in the next step is ventricle start to contract. So as soon as ventricle start to contract with the depolarization or with the electrical activity of in the ventricular muscles, since ventricle contract, ventricular pressure increase, and this valve will close. These valves, tricuspid and mitral valve, will close when the ventricle contracts. So ventricular pressure increase and this valve close, right? So now we get a short time period. This valve close, and already aortic and pulmonary valve also close, right? During this space also, because in this space ventricle relax. So ventricular pressure is low and aortic and pulmonary valve close already. And here also ventricular pulmonary valve close, and uh, and uh, uh, tricuspid and mitral valve also close. That means valve connecting atria and ventricle. But ventricle is contracting. So now we get a situation where all the valves connected to this chamber and this chamber close, but ventricle is contracting. Right. So volume is constant, blood volume is constant, and ventricle is contracting. So if there is a volume is constant and there is no way to move the blood anywhere, and ventricle is contracting because of the electrical activity, what will happen to the ventricular pressure? What should happen to the ventricular pressure? මොකද වෙන්න ඕන ventricular pressure එකට? Increases. Yes, ventricular pressure increases within very short time to a considerably high level. So this line is a ventricular pressure. From here, it will shoot up to here because all the valves are closed and ventricle is contracting. So of course, it's a very short time duration. You can see when you consider whole cycle of the heart, it's a very short time period where volume is constant and contraction of the ventricle occur. So therefore, we call isovolumetric contraction. Iso mean same, volumetric contraction. So in the isovolumetric contraction, ventricular pressure shoot up, increase tremendously within very short period. And at the end of the isovolumetric contraction, because of the high pressure change in the ventricle and because of increasing pressure in the ventricle, in this point, aortic and pulmonary valve will open because now in this chambers pressure in these chambers increase dramatically, and in one point that pressure will exceed the pressure in the aorta and pulmonary artery, and this valve and this valve open. Sorry, you cannot see the valve here. Aortic valve and pulmonary valve open and blood is start to push to aorta and pulmonary artery, right? So until aortic valve and pulmonary valve, that means blood, the valve that move ventricular blood to aorta, left ventricular, right ventricular blood to pulmonary artery, until they open, this time gap, of course it's a narrow time gap, we call it a isovolumetric contraction. So here is the ventricular pressure. You can see ventricular pressure is, sorry, ventricular volume. Ventricular volume is constant because there is no way to move blood because all the valves are closed. But at the end of that, aortic valve and pulmonary valve open, right? Of course, you can understand during this period, considerably very, very dramatic contraction of the ventricle, and of course electrical activity spread mainly during this period or just before this period and somewhere here. So you can see in the ECG, this represent that narrow time period isovolumetric contraction. QRS complex, that is the major electrical event we can see in the ECG, right? When we record the ECG, QRS complex is the major electrical activity. So that major electrical change occur just before this phase. That means electrical activity will spread throughout the ventricle just before the contraction of the ventricle. So therefore, QRS complex that represent the ventricular depolarization. Ventricular depolarization will occur just before this phase. That means somewhere here we get the depolarization of the ventricle. That means with the depolarization, you know, calcium will enter and subsequent ventricle will contract. So ventricular contraction will occur in this space. Isovolumetric contraction. Right. So if you go to this diagram, here electrical activity is spread throughout, and this is ventricular depolarization. So you remember, this is the ventricular depolarization. So ventricular depolarization represent the QRS complex in the ECG, and just after that, we get the isovolumetric contraction. As you can see, yeah, it should be somewhere here. Okay. So now, at this point, as I mentioned you, which valve will open at this point? At the end of the isovolumetric contraction, which valve will open? Mono opened in a valve? Huh? Yes. Yes. One of the within the opened and valve?
Aortic and pulmonary valve.
Yes, very good. Aortic and pulmonary valve open. So with the opening of aortic and pulmonary valve, now ventricular pressure is very high, blood will eject. to the aorta and pulmonary artery. Eject. Ejection means it's like a jumping of blood, pushing of blood. We call ejection, right? We call ejection. It's like in the high pressure system, we will open the valve. Tap එක හරිය වගේ තමයි when we have high pressure, and so blood ejection will occur. So this will of course ventricular pressure increase further, because now still ventricle is contracting. Still ventricle is contracting, electrical activity is spreading, ventricle is contracting, and ventricular pressure increase, and blood is ejecting. Since blood is ejecting to aorta and pulmonary artery, probably you remember this black line representing the pressure in the aorta. Aortic pressure now increase, because now blood is coming to the aorta. Blood is coming, high pressure blood, because ventricle is contracting and pushing blood. So aortic blood pressure increase and ventricular pressure also increase. And what should happen to the ventricular volume? Ventricular volume now. මොකද වෙන්න ඕනේ? Blood is moving away. So ventricular volume is start to going down, right? So the first part of this ventricular systole. So now this is we call real systole. Up to here we call isovolumetric contraction, but here it's a real systole. So with the ventricular systole, the first part is we call rapid ejection, because high pressure system eject the blood. But gradually pressure of the ventricle reduce, but still ventricle is contracting. Ventricle is contracting, but pressure start to reduce. Why? පොඩ්ඩක් හිතන්නකෝ. Just think. Ventricle is still contracting, but pressure is reducing. Ventricular pressure is reducing. Why?
Volume is reduced.
Yes, exactly. Now volume is reducing, right? Blood is moving, so pressure cannot maintain because volume is reducing. So therefore, in the middle of the ventricular systole, ventricular pressure start to go down. The same way aortic pressure also go down, because aortic pressure in the aorta is depend on the ventricular blood that coming to the aorta. So pressure is reducing, but still blood is ejecting. Blood is moving, but that we call slow ejection. The first one is rapid ejection, high pressure. Now pressure is going down, but still blood is moving, but we call slow ejections. From somewhere here we have slow ejection. In the latter part, very last part is just a very slow movement of blood, because ventricular pressure is not a factor, but just since blood is moving, blood will move little bit, and with that we call pre-diastolic, protodiastole. So rapid ejection, slow ejection, and very narrow time we call protodiastole, right? So that is what happened during ventricular systole. Right. So at the end of the ventricular systole, of course, now ventricular pressure is reducing since blood is moving away. And at the end of that, aortic pressure will exceed the ventricular pressure. Right. Now at this point, aortic pressure is higher than the ventricular pressure. Then what should happen? Aortic pressure එක වැඩි වුණොත් ventricular pressure එකට වඩා, since contraction is poor and so on, මොකද වෙන්න ඕනේ?
Aortic and pulmonary valves will be closed.
Yes, very good. So here aortic and pulmonary valve will close. So at the end of the ventricular systole, aortic and pulmonary valve close. So at this point, what can you say about the mitral and tricuspid valve? That means valve connecting atria and ventricle at this when this happen. those mitral and tricuspid valve close or open. During whole systole, whole ventricular contraction, mitral and tricuspid valve close or open.
Close.
Close. If they are open, the blood will go backward to the atria, isn't it? So they are close. So from this point, when the aortic valve, pulmonary valve close, mitral and tricuspid valve also close. Right. Now ventricle is not getting electrical activity anymore. So ventricle depolarization end. So no electrical activity in the ventricle and ventricle depolarization end. So now ventricle start to relax. Right. So next point is ventricular relaxation. So in the ECG during this, this is the ECG, in the ECG waves, this is the duration that we discuss. So now ventricle is relaxing. So in this point, after this point, ventricle is relaxing. So at this point, aortic valve, pulmonary valve close, mitral and tricuspid valve close, and ventricle is relaxing. So what will happen to the ventricular pressure? So all the valves are closed now and ventricle is relaxing. So what should happen to the ventricular pressure? Valve occam close, but relaxing, that means volume is increasing. Relaxing mean ventricular, relaxing mean volume is increasing.
Pressure decreases.
Yes, pressure decreases because now ventricle is relaxing. That means when the ventricle relax, volume is increase because no, there is no contraction anymore. So ventricular pressure decrease dramatically, pressure shoot down. So you can see red line, ventricular pressure go down within a very short period, ventricular pressure go down. Right? That we call isovolumetric relaxation. This period is isovolumetric contraction, this period is isovolumetric relaxation. Right? If the ventricular pressure go down dramatically like this, what can happen? What should happen? Because the pressure, ventricular pressure is going down and down and down. So what should happen?
Blood should come into the ventricle.
Blood should come to the ventricle. Yes, Guru, good. Blood should come from atria to ventricle. Before blood come, what should happen? They come in the blood. So in this period, pressure gradient, very good. Of course, pressure gradient, and in this period, you mentioned that tricuspid and mitral valve are close. So valve.
Valve should be open.
Yes, my tricuspid and mitral valve, that means valve connecting atria to ventricle should open. So in this point, this valve will open and then only we get the blood flow. So up to here valves, all the valves are closed, blood pressure going down, and when this come to this point, tricuspid mitral valve open and blood will enter into the ventricle. So you can see ventricular volume increase now. Ventricular volume increase. And ventricular volume increase, of course, ventricular pressure also increase slightly, and ventricular volume increase because of the moving blood from the atria to ventricle, right? So at the end of the isovolumetric relaxation, so this is the ECG of during isovolumetric relaxation. So at the end, ventricular filling will occur, and now its ventricle is in the diastole. Ventricle in the diastole, AV valve open here. AV valve means atrioventricular valve, right? Tricuspid mitral valve open, and blood will enter to the ventricle. So if you consider about this diagram, and this is what happened: ventricular filling, tricuspid mitral valve open, and blood will come to the ventricle, and ventricular volume increase. So in the ventricular filling also, the first part of the filling is rapid, because there is a considerable amount of blood will retain in the atria, since AV valve, that means mitral tricuspid valve close, and considerable volume of blood retain in the atria, because ventricles are in systole and blood cannot come to the ventricle. Now as soon as ventricular valve, AV valve open, blood will again like pushing to the ventricle. So we can call rapid filling of the ventricle. So this is rapid filling. You can see filling increase quickly, right? So most of the blood will come from atria to ventricle during rapid filling. After rapid filling, this ECG change, we get the slow filling. Slow filling, but still even during rapid fillings and slow fillings, atria are relaxed. Atria are relaxed and there is no atrial contraction, right? But blood will fill. Blood will come to the inferior vena cava, superior vena cava, and blood will come. Blood filling, ventricular filling occur, but atria also in the relaxed mood. Atria also in the diastole, ventricle also in the diastole, right? This is rapid filling, this is slow filling, and this filling will end and atria start to contract to start the next cycle of electrical activity. SA node generate next beat and electrical activity spread to the atria, and when this happen, we will get the atrial systole. So up to here, from here to here, atria in systole, right? So when it come to this point, and in the next event is the atrial systole. Next cycle start. So I start the description with the atrial systole. So atrial systole will occur, and next cycle, and some blood will push further to the ventricle, and ventricular volume increase further, atrial pressure will increase, ventricular pressure will increase, and next cycle will start. So we came back to this point. So we start from atrial contraction, move through these phases: isoelectric contraction, ventricular ejection, isoelectric relaxation, ventricular filling, rapid filling and slow filling, and again atrial systole in the next cycle, right? So this is the very narrow pace of atrial systole. Throughout this cycle, we have atrial diastole. This part is ventricular systole. We have ventricular contraction, the isometric contraction, isometric relaxation, and this part is ventricular relaxation, so ventricular diastole, right? So this is ventricular diastole, this is ventricular systole, this is atrial systole, that means atrial contraction, and this is atrial diastole, right? So that is the cardiac cycle, and that is the mechanical event occur in the heart, and this cycle will continue on and on and on with the generation of SA node generating electrical activity. This cycle will continue. Right, okay. So now you can ask questions. Any questions about this cycle description so far? මොනවද තේරුම් නැති දෙයක් තියෙනවා නම් අහන්න. Yes. You can ask questions about this cycle. Huh? Yes. තේරුම් නැත්තම් තේරුම් නැහැ වගේ ඉන්න එපා, අහන්න තේරෙන්නේ නැති දෙයක්. Okay. Please ask question if something is not clear before I go to the next step. Okay, good. So let's move down. And of course, this is ECG change. We start with this P wave in the ECG, you will learn later. That is represent atrial depolarization. And that is with the atrial depolarization, atrial contraction will occur. And we get the ventricular depolarization, QRS complex. With that, isometric contraction, ventricular systole, and this represent atrial ventricular repolarization and ventricular relaxation and so on. Right. So diastole, we can divide into several phases. This very narrow phase we call protodiastole, and then we get the isometric relaxation, that also diastole, and rapid flow and slow filling. This is rapid filling of ventricle. This is slow filling of the ventricle, and then this one is atrial systole. All are ventricular diastole. Right? 1, 2, 3, 4, 5. These 4 phases or 5 phases are, we can classify them as a ventricular diastole. Remember, ventricular diastole. Usually, when we talk about the heart, we consider diastole is a ventricular diastole. We don't consider atrial systole and diastole too much when we describe the activity of heart. So, diastole, that means relaxing period. All this is relaxing period. This one, and this one, yellow. Only this one is systole, right? But this one is very, very narrow. This one is, of course, narrow isometric relaxation. This one is considerably long. This one is long. And this one is, again, considerably narrow. Only 25% of filling will occur in the atrial systole, but still ventricle in the diastole. But 75% of filling will occur in these period, mainly this rapid filling and slow filling. So that is ventricular diastole. So this one is a ventricular systole. 6 rapid ejection and slow ejection. So I described already, that is ventricular systole, where isometric contraction and rapid filling, rapid ejection, that means rapid ejection and slow ejection. Right. So systole and diastole. And this cycle, so I already explained. And so now I will explain few important terms. Stroke volume. Stroke volume is the volume of blood eject from each ventricle during one contraction. So as example, with the ventricular ejection, some volume will push to the aorta. Some volume will push to the pulmonary artery. Of course, the volume is same. Right side by left side, right side, pressure difference, but volume wise, volume same. So that volume will push in one contraction, we call stroke volume. Then we have end diastolic volume of the left ventricle, right? At the end of the diastole, that means, where is the end of the diastole? So this is the end of the diastole. This one will occur 1, 2, 3, 4, and atrial contraction, still diastole. So this is the end of the diastole. So what is the volume in the ventricle? End of the diastole, that we call end diastolic volume of left ventricle. So actually, that is the volume we have when ventricles start to contract. Okay? End of the diastole volume mean next point is ventricular systole, ventricular contraction. So ventricular contraction, when the ventricular contraction start, this is the volume in the ventricle, end diastolic volume of the left ventricle. Of course, right ventricle also same. Then end systolic volume of the left ventricle. That means ventricular contraction finish, still some volume is in the heart. That is end systolic volume. That means so here, so ventricular ejection occur and ejection finish. When it come to this point, we have some volume remain in the heart, ventricle, not heart, ventricle. So this volume, that means end of the systole, we have some volume in the ventricle, that we call end systolic volume of the ventricle, right? So those are very important volume related to heart. Then we will calculate something called ejection fraction. So this is a fraction. Fraction mean kotasak, bhagyak, right? Fraction mean fraction, right? So ejection fraction mean stroke volume divided by end diastolic volume as a percentage. That mean ejection fraction mean with the ejection, what is the fraction of volume pushing from ventricle related to end diastolic volume or related to volume it had. What is the volume push out? තිබුණ volume එකෙන් කොච්චර fraction එකක් push කරාද කියන එක. Right? Ejection fraction. So volume of blood that as a fraction that push out from ventricle with the each contraction, ejection fraction. So this ejection fraction is important to detect the heart failure. And we can calculate ejection fraction with echocardiography. And this ejection fraction is important to check whether heart is working well. If the heart is not functioning well, ejection fraction will be low. Tina blood වලින් ටිකයි යවා ගන්න පුළුවන්. නේ? Ejection fraction කියන්නේ ඒකනේ. tina blood වලින් හොඳට යවා ගන්න පුළුවන් නම් heart is good. So ejection fraction is we use ejection fraction to determine the action of the heart or function of the heart. There are two types of ventricular failure. With the one type is with the low ejection fraction, and other type is preserve ejection fraction. If the ejection fraction is below 50, we consider it a heart failure with compromised ejection fraction or low ejection fraction. So there are other type of heart failure with the with the normal ejection fraction. So you will learn it later, two types of heart failures. But remember, ejection fraction is important to detect that type of problem in the heart. Right. So this table will show the time gap, time wise. If the heart rate is 75, what are the time spent for each cycle? And the one point I want to emphasize, ventricular systole is relatively short compared to ventricular diastole. So usually we call systole and diastole of the heart that refer ventricular systole and diastole. In the heart, diastole is prolonged. That means relaxing time is much higher than the contracting time. Contracting time is 0.3, relaxing time is 0.5 second, right? So in our heart, we have more relaxed time than the contracting time, or more diastolic time than the systolic time. And this you can understand this leisurely. What is atrial systole? You can see atria systole is very short compared to diastole is prolonged. Right. So when the heart rate increase, our diastole getting shorter than the systole, right? So because diastole is the prolonged, and that will compromise more than the systole when the heart rate increase. Remember that also. Right. So in this diagram, again you can see the same cycle. SA node generate electrical activity and spread. And with the SA node generated electrical activity, this color change represent the contraction. Contraction will occur. Then the next point, electrical activity will spread to the ventricle. Here you can see electrical activity spread to ventricle, and electrical activity spread left ventricle slightly earlier than the right ventricle. That's why I put red cycle here. Right? For the left ventricle, electrical activity spreads slightly earlier than the right ventricle. Right. But in the atria, electrical activity spread early in the right atria than the left atria. Why? Why in the atria we get left atria, we get the electrical activity earlier than the right. Sorry, we get right atria get the electrical activity slightly earlier than the left atria. Why?
Because SM node is present in atrium.
Yes, please, again, please. I didn't get your answer. Because?
Because SA node is present in atria.
Yes, exactly. Very good. Because SA node is there. Because SA node located in the right atria, it get the electrical activity first and then go to the left side. But because of the arrangement of Purkinje fibers, this electrical activity is spread first in the left ventricle. And of course, then left ventricle contraction will occur like this, contraction will occur and go back to a next cycle again. Right. So valve open and close according to the pressure change that you already know. Heart valve will open according to the pressure change. So this is same diagram that I explained, I used earlier. And here we have pressure in the ventricle, here atrial pressure, this is aortic pressure. And here, as I mentioned, this is atrial systole and AV valve close and isometric contraction, aortic valve open, ventricular pressure increase because of the contraction or ejection, aortic pressure also increase. And here we get the maximum atrial pressure and aortic pressure, and then start to going down, aortic valve close, isometric relaxation, then AV valve, that means tricuspid mitral valve close, and then this is ventricular filling, slight change, very small change in the ventricular pressure, and but volume change will occur, of course, and so on, and then come the next cycle like that. So this is the event describe the pressure variation in the atria, ventricular, and aorta. And here that again I explain it, ventricular volume. So with the ventricular atrial systole, ventricular volume increase because blood push to the ventricle, and then constant isometric contraction, and then blood is moving away from ventricle because of ejection, volume reduce. Now it come again, ventricular filling, rapid filling, slow filling, and filling due to atrial systole or atrial contraction. So this is ventricular pressure change. And this is ECG wave. And as I mentioned earlier, P wave is atrial depolarization. That means that initiate atrial contraction. So before atrial contraction, we get the P wave. QRS complex is ventricular depolarization, this complex, and that will get before atrial contraction. And this is ventricular repolarization. You will learn them in your ECG lecture subsequently, and so on. Then this is heart sound. Again, you will learn in the separate lecture heart sound. First heart sound occur with the close of tricuspid mitral valve, and second heart sound will occur closer of the AV valve, sorry, pulmonary and aortic valve, and so third heart sound very rare. So first heart sound, second heart sound, first heart sound, second heart sound. So first heart sound is due to close of AV valve. Right. So ECG, heart sound, pressure change in the ventricle, volume change in the ventricle, pressure change in the atria, ventricle, aorta, all will represent in this diagram. You can leisurely study that. Right. So this diagram is related to left ventricle. Right. Related to left ventricle. Right. Forget about the atria. So related to left ventricle. So just to refresh your knowledge about the left ventricle, I will use this diagram again. In the left ventricle, so this is the left ventricular pressure, right? So during isovolumetric contraction, left ventricular pressure increase considerably, but volume is constant. Pressure change, but volume is constant. Now, pressure increase slightly, but volume reduce because of pushing down. And here again, volume is constant, pressure is reducing, and it comes the next cycle. Because of the filling, ventricular volume increase and pressure will also increase slightly, right? So this will summarize left ventricular volume in this axis and the left ventricular pressure in this axis. The same thing that I described, this diagram summarize volume and pressure change related to left ventricle, right? We can start from somewhere. We can start from here. Mitral valve close, because it's left ventricle. When the mitral valve close, what is the next event? When the mitral valve close, what is the next event? Mitral valve mean valve connecting atria to ventricle. Mitral valve close. What is the next mechanical event of the ventricle? Just after mitral valve close. Yes.
Ventricular systole.
Yeah, ventricular systole. But just before ventricular systole, what is the very narrow time, very narrow period?
Isovolumetric contraction?
Yes, all the valves are closed and ventricle is contracting. That we call isovolumetric contraction. So with the isovolumetric contraction, here you can see pressure increase quickly. Pressure shoot up. So this is the axis of pressure. This is the volume, and volume is constant. Volume, no change in the volume. But the volume, no change in the volume, and pressure shoot up. And at the end of the isovolumetric contraction, what happened? Which valve will open? Aortic valve open. Aortic valve open. With that, what will happen to the volume? When after aortic valve open, what will happen to the ventricular volume? Blood volume.
Reduces?
Reduces. Ventricular volume reduces. You can see this is volume axis. Ventricular volume reduces first rapidly and then not that rapidly. Ventricular volume yes, ventricular ejection will occur. Ventricular ventricular aortic valve open, ventricular ejection will occur. Ventricular volume is reduced because volume, this is volume axis, volume is reducing. Ventricular pressure, what happened to the ventricular pressure with the contraction? Ventricular pressure will increase. This is the pressure axis. Increase rapidly and then gradually increase, and then it will come to a point that is the end of the ventricular ejection. Right? What will happen here? End of the ventricular ejection. End of the ventricular ejection. What is the valve that close? Left ventricle, aortic valve close. Right? So aortic valve close. So that end the ventricular ejection. Slow, rapid ejection and slow ejection. And what is the next phase? Now heart start to relax. Ventricle start to relax. So isovolumetric relaxation where pressure reduced dramatically, pressure shoot down and no volume change. Volume is constant. And now it come to the end of the isovolumetric relaxation where mitral valve open and again blood start to come to the ventricle and blood volume increase. This is the volume axis, and blood pressure also increase slightly because of the filling, and next cycle start. So like that, this is the pressure and volume curve of the left ventricle. Right? So maximum pressure of the ventricle we call diastolic pressure, and systolic pressure. The diastolic pressure is the pressure where lowest pressure in the aorta, where aortic valve open when the ventricular pressure exceed the aortic pressure. Right. So this cycle will continue and continue, And the same thing that I describe, it's in some other way, just to left ventricular pressure and volume. Okay, so this, any questions about this diagram? If there's any questions, you can ask, or you can have a look again carefully. I will give you a 2-3 minutes. You can have a look again and try to, you can ask if there's any question. Right. So, so we had a yeah, almost 1 hour. I think I did very slowly this description for you to understand. So I need another 20 minutes or so on, or maybe more than that. Do you need a break, 5-minute break, or just get a water or something? Huh? I hope I have time until 3:45. නේ 3:45 වෙනකම් වෙලා තියෙනව නේද මට? ඈ? ඊළඟ ඇක්ටිවිටි එක තියෙන්නේ 3:45 වලට නේද? කතා කරන්නේ නැහැනේ. Do you have anything at 2:45? Anything else? Any other lecture or anything?
No, sir.
No. Okay. So, do we need a 2-3 minute break or 5-minute break, or shall I continue? Right. So I will continue and then you can finish. Right. So, okay. Right. So there, when we consider left and right ventricular event, there are some sort of asynchronousness, and things will not occur exactly the same time, right and left. Right atrial systole proceed, that means come before left atrial systole. Right atrial systole start before left atrial systole. Why? I think you know that. Right atrial systole start before the left atrial systole. Why?
Because of the SA node?
Yes, because of the SA node there, electrical activity was spread to the right atrium. Left ventricle begins to contract before right ventricle. Why? Left ventricle begins to contract before right ventricle. Why? I think you know that. Yes, I told the reason.
Higher ventricle pressure than right ventricle pressure?
No, because it's a contraction. Left ventricle began to contract before right ventricle. Yes, I think I told it. Left ventricle එක මොකද පොඩ්ඩකට කලින් පටන් ගන්න contract වෙන්න.
Distribution of the nerves.
Not nerves, electrical activity. Electrical activity distribute to left ventricle slightly before than the right ventricle, right? So I explained that. But right ventricle ejection begins before left ventricle. Right ventricle ejection begins before left ventricle. Right ventricle ejection start before left ventricle ejection. Anybody? Ejection mean just pushing blood from the right ventricle. That means pulmonary valve open just before aortic valve. Why? Yeah, that's because in the pulmonary circulation, pressure is less than the systemic circulation. Since the pressure is low, valve can open early in the pulmonary side, that means left ventricle, than the aortic left side that is reconnected to aorta. Aortic pressure is high than the pulmonary pressure. So this here you have this answer to that. And semilunar valve, that is aortic and pulmonary valve, we call semilunar valve, and this variation is some alteration with the respiration, inspiration and expiration. With the inspiration, more blood will come to the right side. So since more blood come, we will get some slight variation in the right side since we get more blood, and you can read and you can understand that that related to this slight differences in the timing in the right and left. Right. So with increased heart rate, so as I mentioned early, when the heart rate increase, diastole gets shorter and shorter than the systole. Diastolic time gets shorter. Remember, when I say diastole, it's a ventricular diastole. Right? Diastole gets shorter and shorter. And so coronary blood flow, that means blood flow will go to the myocardium. Blood supply to the myocardium is mainly occur in the diastole. When the heart should relax for blood flow to move to the to maintain the blood flow in the ventricle, because ventricular blood vessel will compress with the contraction of ventricle. So in the diastole, we get blood to the myocardium. Myocardium means heart muscle, right? So when the diastole gets short with the increased heart rate, blood supply to the myocardium, that means heart muscles will compromise and we get problem and some risk of getting ischemia or low blood supply. Ischemia means low blood supply to the tissue. That means myocardial blood supply might reduce if we increase the heart rate to a considerable higher value. And so that might make is myocardial infarction. We call it heart attack. You will learn them later. Just read them and later you will understand. Pressure changes. So that's what I mentioned. Left ventricular pressure is, peak pressure is 120 mercury millimeter, but right ventricular peak pressure is about 25. So in the right side, as whole heart, right side we run in a low pressure and left side we run with the high pressure. Right side we run with the low pressure system, left side we run with the high pressure system. You can understand them when you read them carefully. Aorta also same. Aortic pressure is 120, the highest pressure, that means diastolic pressure. Pulmonary highest pressure is 25 mercury millimeter, and systolic of the aorta is 80. This one is 0, and some places, especially atria, sometimes pressure is 0 mercury millimeter. So this is, you get some idea about the pressure changes in the chamber, systole and diastole. As example, in the left ventricular pressure will vary from 100 to 0. Here 25 to 0, right? Systole and diastole. So here, again, atrial pressure is low, but in the left side is, right side is further low pressure in the heart chambers. Aortic pressure and pulmonary pressure, you can see and you can understand them. Just to show you the pressure variation in the chambers and aorta and pulmonary artery, you can study this diagram. ASD, you will learn later when there is a defect in the atrial septum. Usually we don't have this type of defect, this type of hole. More blood will move from left side to right side, and that will alter again the pressure and oxygen saturation if there's a defect here, right? And of course, again, you will learn later about the ASD, atrial septal defect. Atrial septal defect. In anatomy, you will learn, and in physiology also, you will learn some of the changes. Then VSD, ventricular septal defect. Usually, we don't have this hole, right? If there's a hole here, high pressure left ventricular blood will move to the right ventricle, and that will alter the pressure here. So normally it's 25 diastolic pressure, but now here we have 60 diastolic pressure. That means blood pressure increase because of this VSDO, ventricular septal defect, right? And same time, patent ductus arteriosus, I will not describe them. When you learn about the patent ductus arteriosus in anatomy and in the subsequent lectures, you will understand that will also alter the pressure variation in the heart. Here you can see that, and oxygen saturation also. Because with that, as example, here we have more oxygen with high, we have blood with high oxygen in this side and low oxygen with this side. With this mixing, oxygen saturation or oxygen amount will reduce in this side, right? Right. So that about the ventricular or atrial and basically mechanical event of the heart and associated pressure changes. I describe so far. And now from here I will go few slides about the pressure changes in the blood vessel. So as you can see here, when the ventricular push blood to the aorta, we maintain a pressure, some sort of pressure system in the aorta, right? And this valve also will close, and so that will prevent blood is moving back, and so pressure will maintain in the aorta. So like that, we have high pressure system in the aorta and connected artery. Right. So if we get a tube that close both end, pressure is constant, right? Like your water bottle, both ends or leads close, and so pressure is equal inside that. But in the blood vessel, blood is always moving. This is from heart, aorta and artery, arteriole. So blood is moving. Since blood is moving, and we will give resistance to the blood flow, right? So the blood vessel wall will give resistance. Because of the resistance, pressure is going down when the blood start to move. Not like this. Here, pressure is equal all the places, but when the blood is moving in the blood vessels, pressure is going down. So here you can see aortic pressure. Roughly, this is mean pressure. Systolic pressure 120 and diastolic pressure 80. So mean pressure, you can consider this value. And this mean pressure in the aorta is, you can consider 93 in this example. When it comes to the arteries, that means branches of the aorta, pressure going down. Arteriole, that means further branches, small blood vessels, pressure reduced further. Capillary, pressure is reduced further. Veins, pressure reduced further, right? Venules, vein. And when it comes to the vena cava, or when it very close to the heart, again, pressure is almost like zero. So from aorta to veins, or vena cava, inferior and superior, pressure reduce like this because of the resistance. So number of blood vessels in the aorta surface area is like this, but when it comes to the capillary, Surface area is huge because we have large number of capillary network. Number of capillaries very high. Of course, we have one aorta. Since surface area is high here, pressure reduction is more and more here, and the velocity of blood flow also change from aorta to capillary like this. Since capillary is huge surface area, velocity reduce, right? So this is the arrangement of aorta, artery, arterioles, capillary venules, veins, vena cava. This is how velocity, velocity, rate of the blood flow, variation, and total cross-sectional area. In this way, let's say this is from ventricle, left ventricle, aorta, blood is pushing. This is tissue, capillary, and veins, and collecting blood back to the heart. When we come to the aorta and branches, before capillary, we have precapillary sphincters. Sphincters mean it's like a valve. We can control that. We can control by, it contains smooth muscle, we can control. And capillary also we can control by the nerve supply. So diameter of this part we can control, but we cannot control diameter of this part. Here we cannot control. We can control mainly diameter of this part, right? So when we control the diameter, we can change the pressure. Arterial tone, we can control. We can regulate blood flow. We can alter the total peripheral resistance. That means resistance push to the blood flow by the blood vessel. Peripheral resistance. Peripheral can peripheral ne. Durastha. That means blood vessels will give resistance to the blood flow. So that also we can control by acting of this smooth muscle, right? In the capillary and precapillary sphincter and some of these venules, right? So when we constrict the arterioles, right? So this is arterioles, precapillary sphincters and arterioles, right? Not capillary. Sorry, probably I did a mistake. So we can control the diameter of arterioles and precapillary sphincters, not the capillary. Precapillary sphincters and arterioles and venules. When we change the pressure in the arterioles, you can understand if we compress, downstream will reduce and upstream blood will accumulate and pressure will increase, volume increase. Up to here, blood will accumulate and pressure increase. Downwards, blood flow will be low and pressure will be low, right? So that is how we can control the arterioles and precapillary sphincters and control the blood flow to the capillary, right? About pulse. So pulse is some type of wave that generate in the artery walls, right? So probably you know that we can feel our pulse when we press here, we can feel the pulse. So that pulse is not really blood flow. It's a wave of arterial wall expansion, right? Pulse wave will travel faster than the blood, right? Basically, pulse wave faster than the velocity of blood, right? So pulse wave rate is 4 meter per second and blood flow is slower than that. So different type of pulse you will learn in the separate lecture. And there's something called pulse pressure that is different between systole and diastole. So as I mentioned early, in the when aorta exert, when the ventricle exert pressure on the aorta can maintain high pressure that we call systole, and low pressure in the aorta we call diastole, and that difference is we call pulse pressure. Difference between systolic pressure and diastolic pressure is the pulse pressure, and I hope you will learn it again in some other lectures. So pulse pressure will be weak or low when we get the less blood or shock. That means low blood volume, pulse pressure will be low. And there's something called jugular venous pressure, and you will have a separate practical on that. You will learn more about the jugular venous pressure. Basically, jugular venous pressure, we observe in the internal jugular vein. We have vein here connected to the somewhat directly connected to the heart, and where we can measure this pressure, right? So this pressure directly represent the pressure change in the right atrium, right? So right atrium fill and contract, relax, and so this pressure change in the right atrium represent by this wave we call jugular venous pressure change, right? And so in this diagram, I explained this in the right atrial pressure change. So exactly this pressure change represent by the JVP waves, so jugular venous pressure waves, and you will have practical on that and read about the jugular venous pressure. Right. So in the jugular venous waves, we have wave A, wave C, and wave V. And wave A is due to atrial contraction. Here you remember, with the atrial contraction, atrial systole, we get this pressure increase, and that will represent by the jugular wave as A wave. Here, tricuspid valve close, and with the close of tricuspid valve will bulge upward little, and that will get the C wave. And then with the ventricular filling, blood will come to the ventricle, and blood pressure increase ventricle, that will represent the V wave in the JVP, right? So these are the waves in the jugular venous pulse. Right, of course, you will learn about the alteration of jugular venous waves. I will not describe, and in your practical you will learn more about the alteration of condition where jugular venous wave, some A wave increase, A wave absent, and C wave increase, and so on. Right, so that's end, and go to this YouTube video and you will understand, and that will be a very nice video to understand the event of the ventricle. Right. So read about the JVP and try to understand it before you go to the JVP practical or jugular venous pressure practical. Okay. Any questions? I know it's a long lecture. Any questions? 1 hour and 20 minutes or 15 minutes?
Sir, should we know the value of the pressures in the heart?
Sorry?
That means each value of pressures at different part of the heart. Should we
Yes.
memorize?
Good question. Probably not exact value, but you should have some value like this. You should know that, yeah, as example here, you know, this is 25 and this is 100, right? One fifth of pressure in the right side. And atrial pressure is further low, even it come to the 0. So like that, you should have that idea and not exact value. Okay. Yes. Any other questions? Right. So if not, I will stop the lecture now. So have a nice day.